Hello, I'm Weil, Editor-in-Chief of Health Affairs. In 2016, in partnership with the Physicians Foundation, Health Affairs launched an article series on the practice of medicine, focusing on important health policy issues affecting physicians. The effort has produced an impressive collection of research on a range of topics. One critical issue we've covered in the practice of medicine is clinician well-being, and that's the focus of today's briefing: physician burnout, workforce strain, and lessons from COVID. Now, prior to the COVID-19 pandemic, more than half of US physicians were already experiencing burnout, and roughly 30% of resident physicians were experiencing depression or depressive symptoms, a rate that's twice that of US adults as a whole. A 2017 study found nearly 40% of physicians reported being reluctant to seek mental health care because they worried it would jeopardize their chances of obtaining or renewing their medical licenses. 1 in 15 US physicians had experienced suicidal ideation. Now, as we know, the pandemic made things even worse. One systemic review found rates of depression and anxiety at about 1/4 among hospital staff caring for COVID-19 patients. We now estimate 300 to 400 physicians die by suicide in the United States every year, or one doctor a day. We have an outstanding set of panelists, researchers, and health system leaders joining us today to discuss physician well-being. And in recognition of National Physician Suicide Awareness Day, which was September 17th, we hope today's conversation will advance understanding and policy to address the challenges facing the clinical workforce. Before we begin the program, I want to turn to Dr. Gary Price, President of the Physicians Foundation, for some opening remarks. Dr. Price is a board-certified plastic surgeon. He serves as an attending surgeon and clinical assistant professor of surgery at Yale New Haven Hospital. He's affiliated with numerous local and national medical associations and societies, and is a past president of the Connecticut State Medical Society and the Connecticut and New England Societies of Plastic and Reconstructive Surgeons. Dr. Price, we look forward to your opening thoughts on the topic.
Thank you, Alan. I am Gary Price, president of the Physicians Foundation and a practicing surgeon from New Haven, Connecticut. On behalf of the Physicians Foundation, I am tremendously pleased to welcome you to this practice of medicine session on physician well-being. Thank you so much for joining our panel of experts for what I am certain will be a thoughtful and stimulating discussion. Physician burnout has long been a concern of the Physicians Foundation, and our surveys of physicians just before the onset of the pandemic revealed an alarming rate of frequent burnout symptoms of 40% or more. At that time, a growing awareness of systemic issues contributing to frustration in our physicians' daily work environment were becoming obvious, including a loss of autonomy, inefficient electronic health records, and the creep of clinical duties into home and family time, among others. The onset of the pandemic, now more than 2 years ago, compounded what was already a crisis in physician well-being into a significant dimension of the tragedy of COVID-19. In our ongoing surveys, levels of burnout among physicians reached 60% or more at the height of the pandemic. In our most recent survey released just days ago, these levels remain just as high, setting a new grim statistic in the annals of COVID-19. In fact, burnout symptoms were reported at an even higher rate among younger physicians and employed physicians, with female physicians setting a new record at 68%. In that same survey, 80% of physicians felt that there was still stigma among physicians surrounding mental health and seeking mental health care. Only 1/3 of doctors felt that suicide prevention resources exist and are easy to access. The story of a physician who does not seek help when needed because of a perceived threat to their license and livelihood has become all too familiar. I am one of the 38% of physicians who has lost a colleague to suicide, and it is quite likely that many of you on today's call are part of that sad fraternity. It is undeniable that our physicians need and deserve better. Many aspects of the underlying problems have been defined. It is now time to begin to constructively address the causes of this epidemic of burnout with deliberate actions. The Physicians Foundation launched the Vital Signs campaign, which includes practical resources for physicians, their families, and colleagues to recognize and help begin a dialogue when early symptoms of burnout appear. In collaboration with First Responders First and the Dr. Lorna Breen Heroes Foundation, we have sponsored National Physician Suicide Awareness Day. In a joint effort with many of the organizations represented on today's call, we are enthusiastic supporters of the All In campaign, which offers practical goals and concrete actions for organizations to address these issues. The discussion today will approach the issues of physician well-being from several perspectives. I am hopeful that these observations will lead each of you to consider the next steps in effecting systemic changes in how physicians go about their work, reducing the stigma of seeking mental health care and increasing access to that care. We remain very grateful to Health Affairs for the entire Practice of Medicine series, and I thank all of you for your interest and participation today. Alan?
Thank you, Dr. Price, and I particularly appreciate your emphasis on systemic change. At Health Affairs, we're all about policy, both public and private policy, and viewing this as a systemic issue warranting systemic responses is the right perspective, and a theme that I know we'll return to over the course of the discussion today. As I move to our panel, I want to tell the audience, if you're watching us live, you do have the opportunity to submit questions using the Q&A button on your screen. Please try to keep your questions brief, and if you send them in earlier, I'll have a higher probability of being able to weave them into the conversation. Please don't take offense if I'm unable to do so. It's a lot of balls up in the air running the session, but I really enjoy hearing what's on your minds and what you'd like to hear from the panel. We have 6 terrific panelists today. I'll introduce them in a moment. Rather than long opening remarks, I've asked them each just to introduce themselves briefly. And then the conversation is going to flow through a series of topics where I'll ask a couple of them to make some opening comments, and we'll move into a discussion, and then we'll introduce another theme. So we'll start with sort of describing the problem, looking at some of its origins, and moving into the responses. It's now my pleasure to introduce our 6 speakers. They are all medical doctors, which is intimidating for a lowly lawyer like me, but I'm really thrilled to have all of them joining me today. You'll hear from Dr. Chris Sinski, Vice President of Professional Satisfaction at the American Medical Association, Dr. Rachel Villanueva, immediate past President of the National Medical Association, Dr. Samuel Edwards, Associate Professor of Medicine and Research Co-Director of the Relate Lab at Oregon Health and Science University, and Staff Physician and Investigator at the VA Portland Healthcare System. Dr. Edwards had a piece in 2021 in Health Affairs in the Practice of Medicine series that he'll discuss. Dr. Larry Castellino, Livingston Farrand Professor in the Department of Healthcare Policy and Research at Weil Cornell Medical College. He was our advisor on the series for a time and also has a recent paper that he will discuss here. Dr. Vinnie Arora, Herbert T. Abelson Professor of Medicine and Dean for Medical Education at the University of Chicago Medicine. She had a piece in our Practice of Medicine series on earnings disparities between male and female physicians, not the focus of our discussion today, but an important contribution to the series. And Dr. Amy Freeman, Chief Wellness Officer for Hackensack Meridian Health. So welcome to all 6 of you. If we can bring them on the screen, I'll ask you to just go around in the order I introduced you and say a sentence or 2 more than the words I did, so that people have a sense of how you relate to this topic, and then we'll move right into the content. Forgive me if I don't always remember to call you doctor, since you're all doctors, but Dr. Sinsky, why don't you kick us off and talk a little bit about what the AMA is doing in this area?
Sure. Thanks, Alan. So I'm a general internist, practiced for 32 years in Dubuque, Iowa. And lately I lead the team at the AMA and that is working on professional fulfillment and reducing burnout. And we see our charge as to help to create the conditions where joy, purpose, and meaning in work are possible for physicians and their teams.
Great, thank you. And we'll be returning to that in much more detail as the program goes on. Dr. Villanueva?
Hi, good afternoon, everybody. I'm Rachel Villanueva, as was previously stated, immediate past president of the National Medical Association, and the NMA represents Black physicians and patients across the country. And we particularly see the issue of burnout critical in our community and critical to achieving health equity and quality in our communities. And so I'm very excited to be here today. I also serve on the steering committee for the National Academy of Medicine's Coalition on Wellness and Physician Resilience, or Healthcare Workforce Resilience. So we're very interested in making sure that communities of color are represented in this issue.
Thank you. Dr. Edwards.
Hi, thanks, Alan, and thanks for inviting me to participate in this esteemed panel. Samuel Edwards, I'm a general internist, primary care physician at the VA Portland Healthcare System, and also an associate professor of medicine at Oregon Health and Science University. I've studied issues around burnout and work life in primary care in the VA, outside of the VA, and then I'm also the co-director of the Relate Lab at the Department of Family Medicine at Oregon Health and Science University, where we do a lot of work around leadership development and improving culture and well-being. So thanks for inviting me.
Great, thank you. Dr. Castellino?
Yeah, thanks, Alan. I won't repeat what you've already said, but I'll just add that I don't consider myself really an academic expert on burnout, although I've been in academia for 22 years now. But the paper that I'll discuss, I think, is a useful paper. I would say I have very firsthand experience with burnout from 20 years in private practice. Night after night, I'd get home at 9, 10 o'clock. My wife would put dinner on the table and leave me alone. It's not very good for family life. I'll just add also that I knew Lorna Breen. She was a student in an executive MBA class I taught, and she really stood out very early on. She emerged as a leader in the class, and she was, the thing I most remember, she was incredibly generous to her fellow students. When I was told that someone from the class had committed suicide, I wouldn't have dreamed of thinking that she would be someone who would have done it.
Thank you, Dr. Castellino. Dr. Aurora.
Thank you so much for having me here. I am here at the University of Chicago Medicine, and prior to being Dean for Medical Education, I spent most of my career doing medical education research, so have studied burnout in trainees, and immediately prior to this job was working as a hospitalist, as well as Associate Chief Medical Officer of our organization, working on physician engagement right when the pandemic hit. So I'm certainly thinking about workforce resilience is top of mind. I also want to say in my current job, working with students and residents day in and day out, it's very, very salient and poignant when we lose one of our own, not just for the community of trainees that this affects locally, but nationwide. People are watching, and so recent events where we see people, a recent suicide in California of a resident physician, it really takes a toll. And so, thanks for having me here.
Thank you. And Dr. Freeman.
Hi, good afternoon. Thank you so much for including me in this panel. I'm a palliative care physician. That's my background and training. I'm currently the Chief Wellness Officer at Hackensack Meridian Health in New Jersey. And I have the fortunate opportunity to spend all of my time really focusing on decreasing burnout and increasing professional fulfillment among not only our physicians, but our clinical teams. Like Dr. Castellino, I was drawn to this work because of my own experience with burnout, actually as a trainee. So it's certainly a topic that is near and dear to my heart, and I look forward to participating this afternoon.
Thank you. Thanks to all of you for joining us. So as I said at the outset, we're just going to begin with a little bit of a description of the problem. And I'm going to frame my first question this way. There's so much in the news these days about mental health and predating the pandemic, subsequent to the pandemic, people suffering from poor mental health. I'd like to understand, though, the difference between broader concepts of mental health challenges and burnout and clinician well-being in that, with that focus. I've asked both Dr. Jasinski and Villanueva to lead us off in this segment. Dr. Jasinski, I know the AMA has been paying attention to this issue for some time. Can you help us just sort of situate what we really mean when we're talking about burnout?
I'm happy to. I did notice that the internet really cut out for me there, so I'm concerned that you might not hear me. If that's the case, give me a high sign and I'll turn off my video. But you're asking a really important question about, is burnout the same as depression? Is burnout a mental illness? And I think there's a lot of confusion in the medical community about this. And I think it's really important to understand that burnout is not a mental illness. It's an occupational distress syndrome, whereas depression is a really complicated illness that has contributions from the environment and from our biology, but they are distinct entities. While burnout manifests in individuals, it originates in systems. And so when we think about burnout, we have to think about the systems factors, the environmental surrounding in which care is delivered, and that's what's driving burnout.
That's a really important foundational element here so that we understand what it is we're talking about. If you could say a little more about what's changed in recent years, and then I'd like to bring Dr. Villanueva in. We, of course, in COVID heard a lot about the disproportionate burden of COVID on people of color on the disease side, but you focused on the disproportionate burden on the clinical side, and I'd like to hear a little bit about that. But Dr. Jasinski, maybe a little more about where we find ourselves today.
Sure, happy to. We have been studying rates of burnout in a nationally represented sample of physicians since 2011, and we do this at the AMA in collaboration with researchers at both Stanford and Mayo. And so when we first started in 2011, burnout rates were 45% of all physicians showing some sign of burnout. Then 3 years later, it bumped up to 54%. And then the next 3 years, there's been a downward trend. So that last year, in the fall of 2020, about 6 months into the pandemic, burnout rates were actually at the lowest that we have ever seen since we've been tracking them using the same methodology. And that was at 38%. But we felt that the persistence of the pandemic probably has made the second year of the pandemic different than the first. The first year, we were all the healthcare workers, I think, were rising to the occasion, were treated as heroes, et cetera. But by the second year, I think this accumulated stress had really added up. That was our hypothesis. So just last week, we published the results of the same survey, same methodology done now at the end of the second year of the pandemic. And burnout rates had risen from 38% a year ago to 63% of all physicians at the end of the second year. Probably equally as concerning, the number of physicians who would choose to be a physician again has dropped from 72% a year ago to 57%. Likewise, professional fulfillment, 40%, not a really high number, endorse feeling professionally fulfilled a year ago, and now only 22% feel professionally fulfilled. And as has been mentioned by Dr. Price, the pandemic's really been harder on women. Women had a slightly higher risk of burnout than men in our previous studies. For example, a year ago, odds ratio of 1.27 of burnout compared to men. But with at the end of the second year, the odds ratio was twice as high of having burnout among a woman than a male physician. So I think we're really seeing a workforce that is at risk, a workforce that has that the pandemic has taken a toll on this workforce.
Dr. Villanueva, can I bring you in for the perspective of the organization you lead and some of the unique challenges facing Black physicians?
Yeah, thank you. I think the first thing just to really think about is that even when we talk about the research that's being done about burnout in physicians, how things have changed, what was it like before the pandemic, and now as we continue to struggle through the pandemic, you find that there really isn't much data and research on underrepresented individuals in medicine. So we don't even really have really good information, data, or research about that perspective. And even when there is research done, whether it be for educational purposes, trainees, faculty, people in practice, it can often be conflicting information. There's some research that shows that burnout is increased in these populations. Some show that there's no difference, and then while others show that there's more, that they are that we're subjected to, that we experience less burnout. So it really just underscores the need, as we saw with COVID in general, to diversify research, and the need for researchers of color or researchers who are interested in understanding the particular nuances and challenges that are faced by physicians of color and physicians in minority populations. Because even though we understand that physicians may experience more, our physicians may experience increased stressors that should relate to burnout, such as systemic racism from the institutions that they work in, racism from patients, implicit bias, microaggressions in the workplace, all things that really should increase burnout. It's not reflected either because the research isn't there, or there really is, it's a really complex issue to understand. And perhaps the tools that we are currently using to address burnout, some of the tools that we have may not have a good fit for looking at these complex issues. And I think that is really something that, as researchers, I'm not personally a researcher, but as researchers, that really is an important part of understanding that burnout may not affect everybody in the same way as we know for sex. I would say that we also see that, as you mentioned early on with Dr. Sinsky, that there is a conflation between burnout and mental illness. And I think particularly in communities of color, for minority individuals, even though they are physicians or healthcare workers, there is still cultural differences as far as the ability or the ability to access resources. It may be perhaps not for physicians, but other healthcare workers in our ecosystem, but the ability to access, but also cultural differences as far as being comfortable in seeking care when they think it's a mental illness, although we know burnout really is an organizational and occupational issue. And I think that making normalizing and removing the stigma around burnout and really working at system levels for all individuals will really help address issues, particularly in our community as well.
Thank you. I know we're eager to get to solutions and approaches. I want to ask one last sort of level setting question. Dr. Sinsky, I'm struck when I hear you speak about this, the word joy, and I think it's in your title. And my question is joy the inverse of burnout, or is joy the protective salve against the risk of burnout, or is just joy something we should strive for, but it's really completely different from avoiding burnout?
So I think of joy in practice, joy in medicine, joy in work, all as being more colorful ways of saying professionally fulfilled. And I do see it as the inverse of burnout and something positive to strive toward. People resonate with the term burnout, but I think for so many people, the term burnout also is misunderstood to imply blaming of the individual who is affected by that. And so I think it's really important when we talk about burnout to recognize that we're talking about a problem that's located outside of the individual. We know that physicians are much more resilient even than the general population. So the problem isn't a deficit of resiliency in individual physicians. In fact, I've come to speak about the need for organizational resilience. Organizations that have all the infrastructures, the staffing, the technology, the cultural infrastructures that support and protect the individuals within.
Thank you. Well, you talked about the structural issues, and that gives me an opportunity to bring in our two panelists who've published papers in the Practice of Medicine series looking at this dimension. And that will then lead into a broader discussion of causes and structural topics where I know we'll spend a fair amount of time. If I could turn to Dr. Edwards, you had a piece with us on zero burnout practices, and I won't ask you to go through the entirety of the paper, but if you could give folks a sense of what it is you were looking at and what you found, I think it's a great contribution to the discussion.
Of course, thanks, Alan. Yeah, so our study, we studied the practices that were participating in Evidence Now, which was a large agency for healthcare research and quality initiative focused on increasing implementation of evidence-based cardiovascular preventive care practices in small to medium-sized primary care practices. It was a huge project, 7 grantees, 12 states, 1,500 practices. And so in our study, we analyzed surveys from the practices that were administered at the beginning of the Evidence Now intervention in 2015. So well before COVID-19, we asked about practice structural characteristics. We asked every practice member about burnout, and then you asked about practice culture using a measure called the adaptive reserve. So we were really interested in understanding the prevalence of burnout, whether burnout was sort of an individual or practice level phenomenon, and then what structural and cultural characteristics were associated with burnout. When we first looked at the distribution of burnout across all the practices, we were kind of struck to find out that in almost 25% of our sample, none of the practice members reported burnout. So a quarter of the practices were zero burnout, which was kind of contrary to a lot of the narrative we had heard about burnout in primary care. So we thought this was sort of important to highlight and understand. So we performed an analysis where we compared these zero burnout practices with practices where at the very highest levels of burnout to kind of accentuate the differences and figure out what characteristics were sort of those difference-making factors. So first we found out that burnout is definitely both a practice and individual level phenomenon. So it's both. But if one practice, a member of a practice has burnout, then it's a lot more likely than other people in that practice will be burned out. And important to note that our sample didn't include just the physicians, but nurses, practice staff, office managers, so all practice employees. So really supporting the idea that burnout is an organizational level phenomenon that requires an organizational level response. Second, we found solo practices and clinician-owned practices, and practices that did not participate in accountable care organizations were more likely to be zero burnout. We interpreted this as sort of having that locus of control or agency at the practice level is a really powerful protective factor for burnout. And then third, we found a really strong relationship between practice culture as measured by the adaptive reserve and burnout. So adaptive reserve is a measure it consists of 6 domains. So facilitative leadership, work environment, teamwork, sense making, learning culture, and relationship infrastructure. And the association with burnout was strong across all these domains, suggesting they're very interrelated, but was actually strongest with facilitative leadership. So facilitative leadership is defined in this construct as Not a more traditional hierarchical command and control style leadership, but a leadership that really prioritizes fostering relationships, attending to social influence and power imbalances, enhancing communication, assuring psychological safety, and cultivating teamwork. And facilitative leadership can really be thought of as like a feature of practice environments, not just of individuals with formal leadership roles. So one area our study did not cover well that many other studies that people here have participated in is that sort of how the daily operations of practice are associated with burnout. So many studies have shown that like a chaotic work environment or heavy workload, understaffing, inefficient work processes, various features of EHRs are associated with burnout. And we didn't really get at that in our study. But given what we found about practice culture and leadership practices, we've really sort of oriented our work to trying to understand what leadership practices improve culture. So we're conducting a qualitative study of primary care practice leaders about how they manage their teams and mitigate burnout during COVID. And then, my work with the Relate Lab includes conducting and evaluating interprofessional leadership interventions around relational leadership. So I think that's a good summary of the study.
That's great. That's really helpful. Thank you. Dr. Kessler, we looked at a slightly different dimension. I wonder if you could say a little bit about that from your paper.
Yeah. So we wanted to look at the relationship between burnout and the quality and cost of care. And so we thought, as I think most people do, that patients of burned out physicians would wind up with worse quality and possibly higher overall cost of care. There's quite a bit of research that suggests that burned out physicians may spend less time with patients. I'm sorry, let me back up. We thought that we'd find a strong relationship between burnout and lower quality because we thought burnout physicians are likely to spend less time with patients. They may not explain diagnosis and treatment in a way that the patient can understand, and therefore the patient may not do the things they should do to help care for their chronic illness. Burned out physicians may not think as carefully or as clearly about the patient's problems, may not make the extra effort to do a little research to try to understand them better. Burned out physicians might increase the overall cost of care as well. For example, misdiagnoses are very costly, and there's some evidence for this in other contexts that burned out physicians may order expensive tests like an MRI scan, the low back, may order medications that might not be absolutely necessary, just so they can close the visit. That's a good way to close a visit, is by writing a prescription and get on to the next patient. And they're burned out. That's the best they feel like they can do. So in terms of evidence for these kind of things, there is survey evidence that physicians who report being burned out, they also report making more medical errors, being more likely to leave their jobs, being less satisfied with their careers, feeling less responsibility to try to control healthcare costs. And there's been some research that suggests that patients of burned out physicians have a worse experience of care. So this is all very valuable, but there isn't really much objective evidence about whether patients of burned out physicians actually have worse quality. Because if you ask a physician, do you feel burned out, and have you made a medical error in the last year? It could be that they feel burned out now because they feel bad about the medical error, or because they notice them more because they feel burned out or whatever. So that's important research, but we want to try to look as objectively as possible at the relationship between burnout and quality. So we use data from 1,064, a fairly good number of family physicians who were taking their American Board of Family Medicine certification exams. I should mention here, by the way, my co-authors, Diane Rittenhouse from Mathematica, Jing Li from Cornell and now University of Washington, Loris Peterson and Bob Phillips from American Board of Family Medicine, and Diane Rittenhouse and Manyao Zhang also from Weil Cornell. So, okay, we had the survey data in which we had 100% response rate because these physicians had answered these questions to take their exams. So we had survey evidence on how burned out they said they were, or the extent of burnout, or none. We linked this data to Medicare claims data. And the simplest way to summarize our findings is that to our surprise, we did not find that patients of burned out physicians had lower quality as measured by, we looked at ambulatory care sensitive admissions, so-called, to the hospital. And these are admissions for things like asthma or congestive heart failure that may not be entirely preventable with good outpatient care, but good outpatient care may really reduce the number of those admissions. And we didn't find that patients of burned out physicians had higher numbers of those ambulatory care sensitive admissions. Same things with emergency department visits, which also a high quality outpatient care can probably reduce the volume of those. And we didn't find any clear relationship of burnout with costs at all. What we did find, although I don't want to get into the statistical nuances, but we found suggestive evidence that patients of burned out physicians actually didn't have more possibly preventable admissions. They had fewer, indicating possibly better quality of care. Same with hospital readmissions. So it could be, I don't think this is definitive, but this is the best evidence yet that I'm aware of on the topic. It could be that, at least in the short run, patients of burned out physicians may actually get better quality. Now, there are a lot of limits to that. Quality is really hard to measure, and I'm sure people can think of other limitations to our study. But if it's indeed true, and it was pretty consistent finding, the lower ambulatory care sensitive admissions and hospital readmissions of more burned out physicians, it's possible that, as a researcher named Joseph Rabidin and his colleagues wrote, that quality of care may be preserved by burned out physicians, but at great personal cost to those physicians. So it's possible that conscientious physicians may work harder than other physicians, and they may worry more about their patients, and therefore may be more susceptible to burnout, even though the quality of the care they're providing is quite good. At least in the short run. How long that can be sustained is another question. So we'll talk more about this later, but I don't want to emphasize that. Therefore, it's fine to have burned out physicians. There are all kinds of reasons that that's not true. But our findings do suggest maybe that the most conscientious physicians are the ones who are being most punished by burnout, even though they may be providing a higher quality of care.
Thank you. So we're going to move shortly into some systemic responses. This is a terrific foundation. I do want to weave in a couple of questions that I've received from the audience, and I'll toss these out to anyone who feels competent to respond to them. There was a question about whether there's a difference in burnout rates between hospital-based physicians and other physicians. The question was specifically about the increase, but I think it's a general question folks might be interested in. What do we know about locus of practice and its relationship to burnout? Anyone take that on?
So I might be in the best position to answer that, and would have to go back and look at some of our survey data to be precise. But I think in general terms, we know that certain specialties are at highest risk. For example, in our survey at the end of the second year of the pandemic, we found that COVID-facing physicians were at much higher risk of burnout even than the average physician. So in emergency medicine, for example, the burnout rate was 80%. Critical care physicians, it was 70%. And yet our primary care physician rate of burnout was higher than the average for the entire physician population. So that I don't think we can say inpatient versus outpatient is the deciding factor. There's also some difference between whether you're in private practice or private practice or academic practice. But I think the biggest point is that burnout is broad. It's too high among every group and in every demographic setting.
Thank you. That's helpful. And the differences are pretty profound, but as you say, high and higher is not a great not a great basis for improvement alone. There was a question about the role of malpractice. I don't want to turn this whole into a panel on malpractice, but I thought it was an interesting question about whether we have evidence that the fear of malpractice is a source of burnout or the kind of distress that can lead to burnout. Do we know anything about that?
I guess the thing I'll say is there is data that at a different, looking at this from a different angle, that physicians who experience burnout have 17% higher malpractice claims. Now, whether that's cause and effect or which direction would be causal, I suspect you can see it either way. We know that there's that association.
Right. No, that's helpful. And then two questions having to do with the broader care team. One person asked about understaffing, particularly with respect to nursing, which we've heard a lot about, and that is a source of burnout. And someone else asked a question about what we know about the comparison of burnout rates between physicians and other clinicians. Again, we could go a long ways with these questions, but physicians don't practice in a vacuum. And presumably some of the systemic responses we're talking about could have positive or potentially negative implications for other members of the clinical team. Does someone have something to bring to these questions? It looks like Dr. Edwards, you want to jump in.
Yeah, I could speak to this. And we did some studies on burnout in the Veterans Affairs healthcare system during its big primary care transformation, the patient-aligned care teams, which was about 10 years ago. Looking at whole teams, understaffing, definitely an issue for the whole care team in terms of burnout, being associated with more burnout. And specifically comparing nurse care managers in primary care to physicians, physicians tend to be a little bit higher. We saw burnout at about 45% among physicians, 35% among nurses. But an interesting study I'll plug here, we actually looked at how much physicians relied on nurses and how much that affected their burnout. And we found that physicians that relied more on nurses, sort of according to the medical home model, they reported less burnout, but the nurses they relied upon actually reported more burnout by receiving more tasks. So just the way we share work on teams is challenging. It's not simple answers, but I hope that gives some answers.
Yeah, that's striking, and exactly sort of my question of if we look at physicians in isolation, we could actually be proposing policies that are detrimental to other professionals.
Well, if I may comment on
please.
As well. I firmly believe, although I'm not sure there's really conclusive evidence, that well-organized teams can both provide better care and reduce burnout in the long run. But in the short run, and when teams are being created just because someone thinks it's a good idea or to comply with various policies that come from the outside world, there's pretty good evidence that they increase burnout. And I think that's probably, there may be people on the panel who know more about this than I do, but I think that's probably a pretty common phenomenon that's too often overlooked.
Well, that was certainly one of my takeaways from Dr. Edwards' piece about zero burnout practices, was that participation in these various initiatives that may impose upon you to change the nature of your practice, the organization of your practice, can actually be, at least in the short medium term, can be negative from this perspective. And it makes sense if you think about autonomy and control as sources of professional satisfaction. But it doesn't, like so many of these, the short term and the long term, and the voluntary and the mandatory are maybe rather different pictures. Well, look, we've had a great opening, and I've got even more questions from the audience about the nature and origins of burnout. I'm going to set those aside. If we have time, we'll come back later. But so many, of course, in our audience are eager to learn about what to do about this. And so what I'd like to do is first turn to our two additional panelists who haven't been able to speak yet, even though we're so far in. I'm sorry about that. But to talk about what you're seeing and doing in your institutions. And then we're going to pull this all together with some discussion of some of the broader policy threads. But Dr. Aurora, if I could turn it to you, talk a little bit, you said in your opening what role you play, and if you could say a little bit more about what you're doing and what you see.
Absolutely. So in medical education, we respond, we have to respond to accreditation. That's our policy lever. And so our accreditors are the Accreditation Council for Graduate Medical Education and the Liaison Council for Medical Education at both the GME and UME level for residents and students respectively. And both of them have had well-being standards or focus in their site visits. And so this is not new in medical education. And, this has started 20 years ago when I was studying work hours. How do we really ensure that our trainees are able to function? And so I just wanted to share a few things we're doing at UChicago in the training aspect that could actually, a lot of people say, that's a great idea. Could we apply that to nurses? Could we apply that to faculty? A lot of faculty ask us this question. And so working with our GME leaders, our GME office has implemented a toolkit for training programs to address well-being and mental health. And the 3 elements of the toolkit are opt-out visits for mental health. At the very first time you join us, we offer you an opt-out visit for mental health with an employee assistance program, getting at the idea that Dr. Villanueva raised, remove stigma so that you can actually understand the resources available to you when you need it. The second is that a lot of residents work long hours and they don't have time to take care of themselves. Some of the research I did many years ago showed that 60% don't go to a primary care doctor during their residency. And so we created, and a lot of them would come to us and say, we don't have time to go to a primary care doctor because I can't book 3 months out. I don't even have my schedule. And so we said, well, as an institution, we should be caring for our employees. They're vital. And so we created sort of a fast track resident health initiative. They can just email one email and get appointments and get shepherded to consults so that we literally don't have people taking time off because they can't, they haven't been able to see a doctor. And the third thing is really those processing groups. And at the time of transitions, especially right now, as still early in the academic year, our interns meet with various folks that are really PhD counselors, psychologists to process what's going on so that they can learn more. And then lastly, instead of the concept of burnout and well-being, we focused a lot on ease of practice. And so how do we make your life easier? And so we stood up a what to fix program, which has a funny abbreviation that the residents like. And it really is about just send us anything that needs fixing. And so the program is very popular. It's resulted in a lot of sustained fixes. And, this is still early. And I think this relates to something Dr. Sinsky said, which is at least our published data to date by our GME team shows there's no change in burnout rates before the pandemic and during the pandemic, which may not sound so exciting, but as we hear the data, like the fact that we've held steady is something to be proud of potentially. And we think some of these initiatives held steady. And then just related to the question, our frontline residents at our institution obviously do have greater burnout and they need more attention. And so those are the areas that we're really working in, but also never, always trying to get better at what we do. So thank you for having us.
Great, thank you. And Dr. Freeman, love to hear about what's going on at Hackensack Meridian.
Absolutely. So I would say, let me start by saying that I have the good fortune of being able to stand on the shoulders of people like Dr. Sinsky and Dr. Tate Chanafelt and the researchers who are on this call, who have really been, I would say, leading the way, right, with their work. And they've been able to really provide a framework that allows people like me to build from. And so, I do think certainly mental health and well-being is critical in all of this. And so, I'll start with that. I think that when we think about my focus over the last 2.5 years, really, since the pandemic began, a lot of that focus has been on making sure that we have good access to mental health resources. And so what we were able to do during the course of the pandemic is to build on the resources that we already had. We heard from people that we had so many different things. They didn't know who they should actually be calling. Should they be, calling our employee assistance program? Should they go through insurance? How should it work? So we actually created a navigation program, a behavioral health navigation program that sounds similar in many ways to what Dr. Aurora is describing, where it's not only there 24/7 for sort of crisis management, but it also points people to the appropriate longer term resources. So I think that's important. We've really focused on our peer support program as well, really building that up, including both clinicians and non-clinicians in peer support throughout the pandemic. But I think it's not only having the resources, making sure the resources are available, but it's making sure that physicians are aware of those resources, but even more importantly, that they're comfortable in accessing those resources. And I think, this is not something that in healthcare we're good at, and it needs to be just a constant reinforcement of working to destigmatize that. But I think, yes, self-care is critical, but self-care is one small piece of this. And I think, Dr. Sinsky said it before, we don't have a resilience deficit, right? It's not about sort of going out and teaching our physicians to become more resilient. It's really looking at the system and what we can do to support them. And so, one key part of strategy, at least in my organization, is being able to measure and to track burnout and distress. I think we all know that in order to really do meaningful work, we have to have data. We have to be able to quantify it so that we can create meaningful plans and have clear objectives, right? And so this gives us the ability, when we have the data and we understand where we are, to know if our initiatives are actually making a difference. And I think in our organization, the executive leadership team has actually agreed to make the measurement of burnout an important network strategic goal. So it's not just, Amy Freeman as a chief wellness officer, it's our network that is, looking at this as a goal that goes, to our board. Another thing I want to touch on is leadership. So I think we all recognize that physician leaders have a really large impact on the physicians that they oversee. And so with that in mind, in our organization, we've really focused on developing our physician leaders. And we've created a really comprehensive leadership academy. The academy actually spans 4 years of engagement, believe it or not. We have 1.0 to 4.0. And the idea of this academy is really just to be able to equip our physician leaders with the skills and the strategies that we feel like they need to be even more effective, right? To provide the kind of leadership that helps to decrease burnouts in the people who report to them. So it's about meaningful development plans. It's about coaching. It's about really empowering physician leaders to grow and be really intentional and highly effective. And the last piece that I think I want to touch on is thinking about practice inefficiencies, right? And we've sort of touched on that, but I think there is no doubt that our physicians are just incredibly burdened and frustrated when it comes to documentation. And so we really are emphasizing the idea of team-based care when we think about practice efficiency. And it's about trying to decrease that clerical burden that our physicians are facing. And what we're doing is working with our compliance department. We're looking at our policies so that we're making sure that our nurses and our medical assistants and all of the members of the team are able to handle more of that documentation for the physicians, right, within the electronic health record. And that sort of allows our physicians to have a lot greater focus on the patient who is sitting in front of them. And it keeps them from going home and working for hours doing documentation. And also when it comes to documentation, we're really looking at the behind the scenes analytical data in our electronic health record. And that's really allowing us to see, how effectively and efficiently are physicians using that electronic health record. And we're looking at, how much time are they actually spending outside of scheduled work hours documenting? And I will tell you, it's a lot of time. And we want to give them back that time, and we want to be able to decrease that burden. So we've looked at several different ways of doing that. We're providing elbow support and shortcuts to the physicians who struggle the most in the system, but we're also looking at a pilot of virtual live scribing so that our physicians are just really focused on the patient and somebody else is really focused on the documentation.
I'm really glad, Dr. Freeman, you brought up measurement, and I'm thinking of all the work we've done in the healthcare quality movement and setting goals and trying to move the middle as well as the best and lift up the bottom. I hear some really interesting ideas from both Dr. Aurora and Dr. Freeman, and I know the others of you could add to the list of changes within health systems and different approaches. I do want to hope there's a little time to dig deeper into those, but we're a health policy journal, and the moment you start talking about documentation, I start thinking payment models. I start thinking about performance bonuses. I start thinking about the quality infrastructure that I just referenced. I wonder if we could start pulling in, any of you starting to pull some of these threads together around where public policy is either a barrier or a facilitator when it comes to addressing these systemic issues. And I think I'm struck that we have lots of separate conversations in healthcare. If we treat burnout as a problem that's just about this, then we run the risk of forgetting how policy changes we're making elsewhere in healthcare might be affecting it. So I'd love to hear some thoughts about policies that are related to the ability of systems to adopt these sorts of interventions. Who wants to start me off here? Dr. Sinski, please.
Sure, I'm happy to. And I'll start on a positive note. I think that the 2020 E&M coding guidelines that were released were 2020 or 2021 now, I'm forgetting which year, but I think it was 2020, were some of the most impactful changes in terms of workflow efficiency and professional well-being, and being able to provide our undivided attention to patients. Because with those changes, there was a closer alignment between what was required for documentation for billing and what's required for documentation for clinical care. And we were no longer asking physicians and others to be documenting silly things, frankly, that didn't matter: duration, timing, context, modifying factors of a chronic illness. That doesn't add up. So no longer having to meet a certain number of bullet points of history, a certain bullet points of exam, but letting the documentation and therefore the level of service be driven just by medical decision-making, I think was really a brilliant and very important change that's happened. So to me, that's really positive. And I think we've learned from the, I think, emergency waivers, if I'm using the proper term, that were implemented at the time of COVID. So no longer was it only the physician or other licensed independent provider who could enter the orders. And being able to share order entry, team order entry with upskilled team members, I think is important for the practice efficiency that Dr. Freeman has talked about, and to allow physicians and others to spend their time on work that we know is most valuable for patients.
It's a great start to the conversation, and I love that you have some positive things to say. Other perspectives on policy context that could be helpful here?
When you think about stigma around mental health, states in licensing boards and hospital credentialing, all of those kinds of policies have historically been problematic and really prevented care seeking when care seeking desperately needs to happen. And I think there are positive changes being made when we think about the questions that are asked on licensure forms, on credentialing forms, when it comes to history of mental health and medications and all of those things that make physicians afraid to seek healthcare, mental health care. So I do think that we're seeing positive change. It's moving in the right direction.
I will just add that I think, although we're not here talking specifically about gender, it is Women in Medicine Month. And, going back to the paper that we authored on the $2 million wage gap over lifetime earnings that was in Health Affairs in the Practice of Medicine series, I think we do see high rates of women burnout, leaving the workforce, especially those with caregiving responsibilities. And recent papers have looked at, as Dr. Castellino was talking about the conscientious doctor, I was thinking about a paper that I saw that, women physicians were doing more pajama time and managing their inbox basket at night. And that is all uncompensated work. And so, I think as much as possible, when we go to policy, it's to link the payment to the work so that people feel valued. And I think that's the challenge right now, is that, people are trying to do what matters, but if what matters is not valued by the payment system, that's a constant moral distress. And you're not able to spend the quality time with your patient to address their social needs because you have to go to the next patient because of the way the system is set up. And so I hope that new models of payment really help key in on some of that stuff.
That's very helpful. I wonder if any of you want to reflect on the quality measurement enterprise, which is sometimes tied to payment, but also not always directly. Dr. Aurora, what you just described makes a ton of sense. And this notion of alignment between what you're doing, what you were trained to do as a doctor, and then what you need to do to get paid. I could imagine some of the same alignment or misalignment between what you're trained and feel is best for the patient and what you have to do to show the quality measures that you're achieving. Do any of you have comments on whether or not the quality measurement enterprise feels like a potential contributor to either the positive or negative sense of the importance of your work?
I can make a few comments, Alan. First of all, I'd like to say, of all the panels I've been on over the years, I think this is the only one where probably all of us agree about everything, pretty much, because it's kind of so obvious what's going on, and some of the things to do about it are obvious as well. Quality measurement, obviously, it has an important place, but I think a lot of physicians feel like it's gotten out of hand. I think physicians feel like if this big area, this big circle, is what represents the quality of the care they provide, what quality measurements measure is like this little dot, right? And that's without getting into all of the problems with the measures. So it does take a lot of physicians' time, and they don't necessarily see it as valuable. I'll say a little bit. Well, let me say it right now. The focus on financial incentives for physicians over the last 15 years or so has not been good. Whatever one may say about it, I think broadly speaking, one can say it hasn't been very successful in improving quality, except in some specific instances that are quite notable successes. But I think it's safe to say that it hasn't done much for physician morale. It kind of switches from their own intrinsic motivation as physicians to do the right thing to trying to meet what are often seen as pretty narrow, not very useful measures, and it increases documentation burden. There's starting to be more emphasis, at least among some people, on trying to leverage this intrinsic motivation of physicians to get better quality. And I think everybody thinks that if, to the extent that can be done, that will help with burnout. I'll just highlight an article that Michael McWilliams published last year in New England Journal of Medicine Catalyst called Professionalism Revealed. That's very, very good on this. at the risk of going on too long, I just want to add two quick things. One is, if I would say to the audience, if you leave here with, in my mind, if you leave here with one message today, it's to recognize that there's three ways to approach burnout. Because most of the you just hear physician resilience all the time. And that's kind of been an unfortunate term. It's good to be resilient, but it sort of implies that if you're not resilient and you're burned out, it's kind of your fault. So let's make you more resilient. All the help that Vinny and Amy described briefly that their organizations are trying to provide to physicians is great. And that the kind of work that the Physicians Foundation is supporting is fantastic. But resilience is only one way to think about things. There are organizational policies and procedures, and then there are, as Alan said, things that come from what I would call public policymakers like Medicaid and Medicare, and private policymakers like health insurers. And these affect physicians every minute of physicians' lives. I agree with Chris completely that changing the documentation requirements for billing has been huge for physicians and has actually helped morale, I think. But I'll just mention a few of the things that are really killers for physicians right now. And I think the portal is maybe one of the portal combined with the EHR are very problematic for conscientious physicians. So my primary care physician just retired, which is a huge loss for me. I loved him. He was very good. But he told me that, he would actually go home by 5:30 or 6. But then he would work an hour in the evening, and then he would get up at 5 a.m. in the morning and put in 2 to 3 hours every day before going to work, mostly on the portal. The portal is a good thing. It's a great way for patients to communicate. But to my knowledge, no organization has really figured out a way to deal with the volume of requests for help that come in through the portal. People are trying all kinds of things, but my physician at least was doing 3 to 4 hours of basically unpaid work a day documentation and portal. I know that Chris has been too modest to mention it, but Chris has done a lot of work. And I think a lot of that's available through an AMA website on ways to make practice easier on physicians, ways to deal with portals, things like that. And then I'll just mention his public policies. In addition with measurement, which is huge, there's MIPS, which purports to measure individual physician quality and make it public. I don't know any physician who thinks that it does a very good job of measuring quality, and it does take their time to the extent they pay attention to it. And then there are things from insurers like prior authorization requirements, which can take a lot of patient, physician, and staff time and drive physicians crazy when they seem irrational. So that I'll stop with that. But just remember that there's resilience, but there's also organization policies and procedures and private and public policies of health insurers and Medicare, Medicaid. And as long as those things are not improved, there's going to be high rates of physician burnout, no matter what we do to try to make physicians more resilient. But I will add, I will add, if I may, that the kind of things Vinny and Amy were discussing might very well have saved Lorna Bream's life, I think, if they had been affected, or if she could have been influenced by them.
Dr. Sinski, you were going to jump in. Yeah.
Yeah, I was just going to jump in and say that I think we can't overestimate the impact of administrative burden and its role on reducing the quality of patient care. And I think there are so many initiatives that have developed over the years, each one individually meant with good intention, but the cumulative effect has made it so the opposite effect has occurred. And so that instead of a safer environment, we have a less safe environment for patient care. And I think of that as sludge. And there is so much sludge that is clogging up the gears of healthcare that's preventing nurses and physicians and others from meeting their aspiration. And so quality metrics would be one part of that sludge. And there are lots of other pieces. And some of that does actually start with federal or state regulation, but all of it's enabled by the electronic health record. But much of it is exacerbated by an overinterpretation of those policies at the local level. So a compliance officer may think that out of an abundance of caution, they'll just take the most restrictive approach for institutional policies. So we've created 2 resources at the AMA. One is debunking regulatory myths. So there's many myths that we've been able to go back into federal language and clarify for institutional leaders. And another is a de-implementation checklist that we ran past the Joint Commission. So we know that the things that we identify there are consistent with Joint Commission policy. And so one example that we recommend that an organization de-implement is the requirement for password revalidation. So a physician's already signed into the electronic health record, and then they're changing the acetaminophen dose, or they're adding a blood pressure medicine. And in many health systems, that requires another username and password. And that is a redundancy that just is one more sludge, one more nick, one more pebble in the shoe, and you add it up and it's a lot. So as an example, Kaiser Permanente in Southern California recently turned off their requirement for password revalidation and identified that they impacted 1.5 billion orders per week. Their chief wellness officer emailed me, and the next day, she emailed me a couple of days before to say this is coming. And the next day she emailed to say her neck didn't hurt so much because she was no longer having to do the badge login over and over again redundantly. And so there's so much opportunity to remove that sludge, but we have to actually see it as a problem. And in some cases, we have to work together across different sectors to remove some of that sludge that was well-intended when it first began, but is no longer really serving its purpose.
And I will add, I think that's so critical, Dr. Sinsky, what you're saying. And as a chief wellness officer, I sort of see myself as an integrator, working with our compliance officer, working with our IT team, working with our clinical teams, trying to understand what those barriers are, what those issues are, and how we can resolve them. And all of those tools that you have built with the AMA, I've found to be incredibly useful.
Dr. Villanueva, I'm going to put you a little bit on the spot. I hope you don't object. I think Dr. Castellino's comment that this is a panel that everyone would agree is a good starting point, but I want to ask you if it's an ending point. So it's hard for me to imagine that there would be broad disagreement about administrative simplification and things that are frustrations. But in your opening comments, you made reference to things like microaggressions and professional advancement barriers for people who've historically been underrepresented in medicine. And I suspect there may be wellness and burnout issues related to those that you hear about that might be higher on the list in some of the rooms you're in than some of the broader administrative tasks. And I don't mean to make this as one versus the other, but I just want to make sure we're attending to the breadth of the issues. And so I wonder if you could, again, I'm putting you on the spot, but I wonder if you could comment on some of the dimensions of burnout that might be, as I say, topics that come up in rooms you're in that perhaps not others are not in.
Right. No, and I think that's, thank you so much, because I think that's the importance of having someone who represents those rooms where others may not be, and represent a population of our healthcare workforce that is underrepresented and whose issues are really not often integrated into larger policy. I think the fact that the National Academy of Medicine's national plan for the healthcare workforce really takes into account not only physicians, but other individuals in the healthcare workforce, really takes into account the fact that many of those individuals are underrepresented minorities as well, looking at payment, looking at factors that may not be factors that actually affect a physician or a nurse, but will affect others that are in the healthcare workforce. And as you said, the issues that physicians of color face in the as far as burnout's concerned are all the issues that we talked about today. And then in addition, right, we know that there's systemic and structural barriers to the patients that we take care of. There's bias in our healthcare system. That's really the system that we, our system is based on these biases. Our research is based on biases. We continue to use biased algorithms in medical care to this day. And so we can't think that those systemic and structural barriers are only affecting our patients and not affecting those individuals that train and work and try to have a career in a professional environment in that medical environment. In our national meeting this past summer, one of the plenary sessions was the survival of the Black physician, wellness, resilience, and the impact of racism. Because really, there is a strong, unfortunately, there's been recent research that recent information of the numbers of Black residents who are disproportionately kicked out of training programs. And I really find it hard to believe that we have an overwhelming number of Black physicians that can't function in our healthcare, can't function in their residency programs. And there's really not structure, and there's really no, as far as in the educational, medical education, there's no, oftentimes not a, how should I say this? There's not enough of a structured ability to not only they're reported, but the structure that each individual residency program uses for these particular issues is different. And I think that there are many areas as far as training and education, and even for physicians that are in practice and academia, there are many areas where there needs to be a greater attention paid to how bias and racism towards individuals in the system plays a factor in their ability to advance, in their ability to get academic promotions, and their ability just to get a raise in the system.
Thank you. We're coming toward the end here. I know we beat up a little bit on the quality measurement enterprise, but one of the things it did in some areas was change the language within healthcare from these bad outcomes are inevitable to, wait a minute, what if we measure and actually do some root cause analysis and compare ourselves to others who are doing better, we can drive these numbers down. And we've had some real sustained improvements in certain areas. I want to be clear about that. And then I think about, forgive me, but I'm in the DC area. We have, Vision Zero, which is zero pedestrian fatalities. And every year since Vision Zero has been implemented, the number of pedestrian fatalities has gone up, and you sort of just feel resigned to the inevitability of pedestrians dying on the streets. So I use those two as exemplars or as data points for asking the question, can we have quantitative, quantifiable targets that are measured, that make their way up through the decision-making structures of health systems and make their way into the public policy debate to show, as we hopefully move through some of the worst increases that we saw, somewhat delayed, as mentioned in COVID, to drive concerns about burnout and poor well-being down, and to actually have goals for how healthy and how much joy this workforce should be experiencing. Can we turn this into something like a quality enterprise where we're measuring constantly and improving and having dashboards? Or is this too soft and it's just systems and interventions that we know would be helpful? I know it's a long question, but policymakers love targets and numbers, and I'm just curious if this is ripe for that.
So I'm happy to take the first crack at that if no one else speaks up. So I think it's a really interesting question. What should we measure to lead to better outcomes? And I think we've been measuring things in very narrow lanes And I think what we've measured is based on a conceptualization of healthcare as a transactional enterprise. And yet fundamentally at its core, I believe healthcare is relational. And we have not really developed or measures of relationship, and we haven't incented that. So one hypothesis I have is, what if we measured and managed to undivided attention? And we created work environments that were managed to maximize the amount of undivided attention that clinicians gave their patients. My guess is that that will lead to a lot of the outcomes we seek, quality and cost outcomes. Likewise, I wonder, and I think it's possible, so we have a measure of undivided attention using electronic health record audit log data. And so my hope is that that research realm does show us some data that's helpful. And what if we were able to measure the degree of relationalness, the amount of relational emphasis that a health system has, not just between physicians and their patients, but between nurse practitioners, physicians, and nurses and MAs, between one unit and another. And my belief is, and there is some there are small studies that would support this, that the more relational, the stronger the relational infrastructure, the better the outcomes. And so I think in some ways, we've sort of been using the wrong measures for a complex adaptive system like healthcare, where patients don't generally come in stereotypic form, but come with all their own unique combinations of issues.
That was great, Dr. Sinsky.
Yeah, that was great. That was great. Keep going.
Hard agree on all that. I'm a big believer in relational practices and thinking about health systems as complex adaptive systems. I was going to just sort of think an anecdote about our own clinic. Yes, I totally agree. Quality measurement has gotten out of hand. We do it too much. But in our practice, we have a small group that does quality improvement every week. And we gripe about measures and we complain about this. And then we get down to work. But what we're really building is a team that has trust, that works together on complex problems, that we can reach out to one another outside of clinic, and we know that things are going to get done. And we're really building a sense of relationality that allows us to cope with all the challenges of challenging patients, new measures that we don't agree with. And we've built this core, and we haven't measured it, but it feels like adaptive reserve that really allows us to cope. And shockingly, over time, our team is suddenly like performing really well on all these measures. So, I think there's a place where traditional quality measurement and measurement of sort of relationality and team function can synergize. But I love that direction.
So I think that's a great place to bring this conversation to an end, although I know we could keep going. But I really like, Dr. Edwards, how you have sort of brought us full circle, that whatever the limitations of the quality measurement enterprise may be, they can also be a source, a foundation for building teams to try to improve performance to the extent that it feels like the quality enterprise actually is of clinical importance and meaning. And in so doing, could actually address exactly the topics that we've been discussing here today around burnout and value of the work, because the whole purpose of the team is to demonstrate value and improve value and share frustrations, both the negative and the positive. So that's a really nice way to think about it. I'll leave you all to continue to ponder the charge that I think Dr. Sinsky answered really beautifully at the outset, which is, how do we build this into practice in a way that makes its way up to the leadership and makes its way into the policy discussion, so it's not a one-off or each institution left to its own to try to figure it out. So my thanks to all of you, Dr. Sinsky and Villanueva, Drs. Edwards and Castellino, Drs. Aurora and Freeman, great to have this conversation with all of you on this critical topic. Thank you, Dr. Price, for the leading comments, and to the Physicians Foundation for supporting this and the broader work that we've done around the practice of medicine. To those of you in our audience, I would just note that we have a lot more coming, and you can find it all at healthfairs.org. Just tomorrow afternoon, 3 o'clock Eastern, I will host a policy spotlight featuring Jonathan Blum, Principal Deputy Commissioner and Chief Operating Officer at CMS, the Centers for Medicare and Medicaid Services. Our October issue is devoted to the topic of disability and health. We have a number of events, including our briefing on that issue at 1 p.m. Eastern on October 3rd, the day the issue comes out. October 6th, the community-based event in Rockville, Maryland, at a center that serves people with disabilities. We'll have journal club and professional development events as well, built around the topic of disability and health. It's a big, important issue for us. We do have a new exclusive program called Health Fairs Insider. It's a membership program that offers access to content beyond the journal, and that gives you access to the journal club, lunch and learn, professional development, and more. And we have industry leading perspectives every day on Forefront, which is open to all for free. So thanks again to the Physicians Foundation. Thanks again for the thought leadership and the active participation of our speakers today. To the audience, you brought in some great questions. I hope I was able to represent you appropriately in the conversation. I feel like this is exactly what we love to do at Health Affairs, which is take a really important issue in healthcare and break it down and figure out what the ties are to policy. And I hope we've helped you do that today. Thanks for joining. And with that, we are adjourned.